Good afternoon. Thank you for joining today's RLS Foundation webinar titled Sleep and Mood for RLS. My name is Adriana Colucci, and I'm the Communications Coordinator at the RLS Foundation. The Foundation's 2025 Educational Webinar Series is a program aimed at addressing topics that are relevant to the RLS community through monthly expert-led webinars. We are using Zoom webinars for this program to ensure a seamless viewing experience. Please confirm that your Zoom Workspace app or browser software is up to date. Following the live webinar, the recording will be made available for active members to view through their online member portal. If you would like to view webinar recordings and are not yet a Foundation member, we invite you to join online today by visiting www.rls.org. Please be aware that all attendees will remain on mute during this hour. Following the slideshow presentation, the speaker will answer only pre-submitted audience questions. As always, individuals suspecting that they may have RLS should consult a qualified healthcare provider. The information offered in this webinar is for informational purposes and should not be considered as a substitute for the advice of a physician. All right, I'd like to welcome Dr. Koo, who is our speaker today. He is a member of the Foundation's Scientific and Medical Advisory Board. Dr. Koo serves as the director of the Sleep Laboratory at the Connecticut Veterans Affairs Healthcare System, and he is the director of the Yale Center for Restless Leg Syndrome, a certified RLS Foundation quality care center. Dr. Koo is board certified in both neurology and sleep medicine, and much of his research lies in those areas. His research on RLS and periodic limb movements have included animal modeling, epidemiology, proteomics, and genetic analysis. Thank you, Dr. Koo, for sharing your time and expertise with us today. I now invite you to begin your presentation.
Well, thank you very much, Adriana, for the kind introduction. And we're going to talk today about depression and anxiety and restless leg syndrome. It's a topic that is very important and unfortunately something that we see very commonly in the clinic and that patients suffer with very commonly. So the outline of the talk, we're going to talk a little bit about quality of life in restless legs. We're going to talk a little bit about the epidemiology of restless legs. We're going to talk about depression itself, what defines it. And we're going to spend a little bit more time on issues in treating depression and issues with depression itself, specifically in the setting of restless legs. And we're going to end by talking a little bit about suicidality in restless legs. So restless legs is a seemingly simplistic disorder in which one has an urge to move, usually the legs, often associated with uncomfortable sensation. Symptoms are worse in the evening, they're worse with inactivity, and there's temporary relief with movement. So it seems simple, but it's not so simple. So in addition to impacting sleep, it has kind of a far-reaching impact on other kind of body systems and organs. The presence of restless legs increases cardiovascular risk, increases the risk of peripheral vascular disease. It has relations with different endocrine or hormonal disorders such as hypothyroidism. It likely has an interaction with the peripheral nervous system because patients who have peripheral neuropathy often complain of restless legs. And of course, likely the origins of it likely come from the brain, and of course, it has effects on sleep. Now, we're going to talk more about its effect on mood, which also has its basis in the brain. First, we're going to talk a little bit about kind of early descriptions of restless legs. So some of the earliest descriptions go back to the 17th century by the British physician Sir Thomas Willis in this publication, in which he had a pretty good description of it. So he says, "Wherefore to someone being in bed, they betake themselves to sleep, presently in the arms and legs, leaping and contractions of the tendons, and so great a restlessness that the diseased are no more able to sleep than if they were in the place of the greatest torture." And so I think this is a pretty good description because it gets into kind of the agony that occurs at night. And I think torture is could be kind of a fitting word because it can be very, very torturous. And it also suggests that with torture, there is some amount of kind of mental suffering. This is another kind of early description of anxiety that occurs in the legs. So anxietas for anxiety, tibiarum. Tibiarum is kind of a Latin for legs. So this is a German description of restless legs and the co-occurrence of depression and anxiety. Um, so in addition to kind of the urge to move, it can be associated with anxiety, fatigue, headache, high blood pressure, and depressed mood. So it was really kind of understood early on, even about 150 years ago, if I'm doing my math correctly, 160 years ago, that restless legs was associated with problems with mood. So we're going to talk a little bit about studies, and then after that, we're going to get more into probably what is more pertinent to everybody is kind of what to look out for in terms of symptoms and how you might help yourself. So these are some large studies, this one in Sweden, 4,000 men, in which they compared people, men with restless legs to without restless legs, and depressed mood was seen about 2.5-fold more frequently in men with restless legs. Social isolation about the same. This is a study that was done in the United States, comparing, again, people that had restless legs, often or very often to people that don't. And about 40% of the ones that had often or very often restless legs had poor mental health all days of the previous month. That's very unfortunate. So 40% of patients that often or very often had restless legs describe themselves of having poor mental health in general. So this is kind of the largest epidemiologic study that we've had that was now done about 20 years ago that encompassed several countries in across 2 or 3 different continents. It involved about 16,000 patients. The countries included the United States and several European countries. Asked about restless legs and the severity of restless legs, but also a large part was uh, kind of to catalog what other symptoms they had. So, this is a study we often quote to say what the prevalence of restless legs is. And so we quote this as any frequency of restless legs, the prevalence is about 7%. At least twice weekly is about 4%, and twice weekly with at least a moderate amount of distress is about 2 to 4%. Interestingly, when you look further at kind of symptoms that bother people the most, it's usually going to be symptoms of sleep, but also the symptoms have a negative influence on mood. So about 50% of patients with restless legs did say that the symptoms negatively influence their mood. So they also looked very closely at quality of life. They used this very often used and validated scale called the SF-36, which looks at different aspects of life and assesses equality. And so you could see here, the bottom panel, you could see the restless legs are these dark circles. And you could see that they scored on par or even lower than people that had diabetes, osteoarthritis, and depression. Well, the depression ones, of course, the people that are chosen for depression are going to score worse on the emotional aspects. But across, you know, many domains of quality of life, including physical functioning, bodily pain, general health, vitality, and then emotional and mental health. Okay, so what is depression? So luckily in medical school, a fair amount of the education is devoted toward psychiatry. And in psychiatry, one of the most kind of common disorders is depression. So what is it? So this is the DSM-5, which is the Diagnostic and Statistical Manual that psychiatrists use to diagnose different psychiatric conditions. And so it's kind of long, but depression is kind of a constellation of symptoms. But the key to depression is that the symptoms are pervasive and they've been present for at least 2 weeks and represent a change from previous functioning. And at least one of the symptoms is either depressed mood or loss of interest or pleasure. And so we could just go through depressed mood most of the day, nearly every day, markedly diminished interest or pleasure in all or almost all activities most of the day, significant weight loss when not dieting or weight gain, or a decrease or increase in appetite nearly every day, insomnia or hypersomnia nearly every day, psychomotor agitation or retardation nearly every day, which means people have problems moving at a brisk pace. There's a fatigue or loss of energy. There's feelings of worthlessness or excessive guilt, difficulty with concentration, and recurrent thoughts of death, suicidal ideation. And usually with diagnostic criteria, there's disclaimers um, about things not being accounted for by another medical condition, is not attributable to physical effects of a substance or another medical condition, and that there is some amount of impairment in social or other areas of functioning. So these are criteria, but what we all learn in medical school is this mnemonic called SIG-ECAPS, and it kind of just reminds you of what the different symptoms of depression are. So S for sleep disturbance, I for interest or pleasure, G for guilt, E for energy, C for concentration, A for appetite, P for psychomotor retardation, and S for suicide. But remembering that at least you have to have at least a loss of interest or a depressed mood that lasts for 2 weeks. Yeah, so a good question is, because it's very normal for all humans and even animals to get sad. Sadness is kind of a normal part of life, and it's actually important that you become sad, because if you don't become sad, then you do very strange things probably. But the important difference is that sadness is temporary and often can be situation based. If you have a pet that dies, you're going to be very sad. Um, but sadness is more of a temporary situation. So if you're sad and if you've just lost a important, tennis match or something, you'll be sad. But if your friend says, it's okay, you'll do better next time, and you go out and have a meal, then you can, and that person can cheer you up. That's probably normal sadness. But if the sadness kind of gets a lot worse and you can't stop thinking about it, then it spreads to negative feelings about something else. And even if you get taken out to dinner, you are not able to be cheered up, or you just might decline the invitation because you don't want to do that. Then you start wondering, are you depressed? So last for weeks or longer. So the criteria say 2 weeks, but most of the time, if you are depressed, it's going to be for longer than that, months or even years. So you cannot snap out of it, interferes with functioning. So you might begin avoiding social activity. You might not want to exercise. You may want to just stay in the house. And it's just a very pervasive, kind of weighed down, dark feeling. So there are definitely degrees of depression. Um, And if you think about the symptoms, there are a lot of different diagnoses that will like restless legs, for example, you will have problems with sleep, you may have problems with energy, but you may not. If you don't have any other symptoms, then that just might be you're having symptoms from a different disorder, not depression. But there are also um, when depression gets severe, that's when it becomes dangerous. So it's very important to be able to recognize the symptoms of severe depression. And this goes for physicians or care providers, but also for people, because if you have any of these, then you might be severely depressed. So if you feel very hopeless or helpless, and if you feel that life is not worth living, these are signs that you might be severely depressed. And by hopeless, it's not that, oh, it's hopeless. I'm not going to be able to do well in this do well in my tennis match. But then you have the match and you don't necessarily feel hopeless. The hopelessness, helplessness should be a pervasive feeling that you feel totally trapped, that you cannot do anything for yourself. And this feeling is not just momentary, it's present for weeks longer. That's what that is. This word anhedonia is pleasure. So the inability to feel pleasure. And so what this is you're not able to enjoy things that you once were that you usually enjoy. So if you're a person that likes to go to the movies and you just have no interest in going to the movies, and even if you go to the movie, you're not able to enjoy it at all, that is possibly anhedonia. And again, shouldn't just be kind of like one time, I went to the movies, I really didn't enjoy it. It should be, something that happens on a day-to-day basis for a period of weeks to longer. And then, of course, one of the most severe symptoms of depression is suicide. So, but they're also kind of, and maybe we'll talk about suicide a little bit more later. Okay. Another good thing to talk about is the interaction and the coexistence of depression and anxiety. They often will occur together, but they're different things. So depression, we kind of define. Anxiety is worry and kind of a pervasive feeling of worry and inability to kind of relax. There certainly is kind of overlap, but in depression, social anxiety is quite common. That could lead to isolation, avoidance of social situations. And unfortunately, as social kind of beings, we need that social interaction to feel happy and to feel good about ourselves. So unfortunately, that isolation can lead to a worsening of depression, which in turn can lead to more social anxiety and an unfortunate kind of vicious circle. You could also have anxiety about work or occupational activities, and have very task related anxiety, not able to kind of feel like you can tackle that project at work, or at home. And this will lead to complete avoidance or poor performance, and then a decrease in the feeling of self-worth, which can obviously lead to continued feelings of depression. So causes of depression. So in general, there are biologic predispositions or genetic predispositions. So depression can run in families for a number of different reasons. We often hear of serotonin, kind of the happy neurotransmitter, that people with depression may have an imbalance or a decrease in serotonin. So many of the antidepressant medications lead to an increased availability in the brain of things like serotonin, norepinephrine, and dopamine. There can be hormonal changes that are associated with depression, namely sex hormones like estrogen and testosterone. If they're low, can lead to changes in mood. Certainly, there's psychological factors that cause depression, and these are somewhat learned. So, if one has negative thought patterns that they may have developed in life, if they were in a stressful situation and didn't really have much support from either a parent or a teacher, and were often being criticized, person may form a negative thought pattern in that whenever something goes wrong, it's their fault and they're no good, and things like that. Um, and certainly there's social factors. We talked a little bit about trauma or early life stress, but if you have severe trauma, like if you are um, the victim um, um, of physical abuse or sexual abuse, certainly that's a trauma that could lead to depression. Unfortunately, people will often turn to substance use like alcohol to help kind of deal with anxiety and or depression, which can make things worse. There might be a lack of social support and just a general sense of loneliness. And so there are many different medical conditions that are linked to depression. There can be hormonal endocrine disorders like hypothyroidism. Certainly there is an important and very common co-occurrence of chronic pain and depression, heart disease. Basically, any medical disorder you can think of can cause depression or worsen depression, and sleep disorders is very prominent among them. We're talking about restless legs. Yeah, and the question is when, one question might be when should one seek help? And I think that seeking help early on, very early on, is always a good idea. Certainly, if you have symptoms of severe depression like hopelessness, helplessness, loss of interest, thoughts of harming yourself, certainly you should seek help. But even if you don't have any of those symptoms of severe depression, even if you're just beginning to feel sad, it is a good idea to talk to your doctor and uh, yeah, talking to your primary care doctor. Let's see what my next, um, who can either talk to you about medication, or it's always good to talk to somebody about your feelings. And we'll talk a little bit more about that. Okay. So the screening tools for depression are going to kind of mirror what the diagnostic criteria are. So this is one commonly used screening questionnaire for depression. It's called the PHQ-9, or the Patient Health Questionnaire 9, and you see, not surprisingly, has 9 questions. It asks, over the last 2 weeks, how often have you been bothered by any of the following? Little interest or pleasure in doing things, feeling down, depressed, or hopeless, trouble falling or staying asleep, feeling tired, having little energy, poor appetite, feeling bad. And so you can score a maximum of 27, and if you're not depressed at all, you would score a 0. And so if you score 0 to 4, the guidance here is that the person may not need depression treatment. 5 to 9, you may have mild depression. And this is kind of, this language is geared toward a medical professional, but you could kind of think of it as, that if there's functional impairment, the person may need treatment. If it's moderate, it's the same thing. Moderately severe, then more aggressive treatment is probably warranted, including medication and psychotherapy or a combination. And if severe, probably medication and psychotherapy. This is just another geriatric depression scale. Um, you know, this has 15 questions. Again, kind of modeled around the diagnostic criteria. Okay. So now we could just kind of think about why restless legs might be associated with depression. And so, in addition to the association with mood problems, one of the symptoms that bothers people with restless legs the most is the sleep disruption. Um, so sleep disruption, you know, most of us are trying to go to sleep at night when you can't sleep. Even if you have a bed partner, but they're sleeping, you feel very isolated. You feel like you're the only person in the world that is suffering. Unfortunately, the RLS cannot be seen or experienced um, by a loved one, a partner, a family, or friend, and in that way can be further isolating. It might even be minimized by family or friends. We talked about suffering in the middle of the night. We're going to talk more about this, but RLS medications themselves can cause depression. And then, it's very, very possible that there's something about the biology of restless legs that is directly causing the depression. There's a kind of an uncertainty whether the depression of restless legs does it work through sleep disruption, because if you disrupt anybody's sleep, then they may become depressed. Or is there something inherent to restless legs that is causing the depression? Okay, so I thought I would talk a little bit about kind of treatment of restless legs um, in general, and in this way, you could think of it as, how might, because for sure, if your restless legs is not treated optimally, you're not, that usually means you're not going to be sleeping well, and that you're going to be more susceptible to depression. So sleep hygiene is important, having a regular bed and wake time, avoidance of alcohol, very important, because alcohol will definitely make restless legs worse. So anyone with restless legs that is occurring regularly should not be drinking more than one, maybe two times a week. And that includes one drink. If you have regular restless legs, you should not be having one drink every day. That is not recommended. Um, it's important to review medications because antidepressants can worsen. We're going to talk more about this because it's very tricky. Antidepressants can worsen restless legs. Antidepressants, certainly when someone is depressed, are very important, but there's certain antidepressants when you have depression and restless legs that should be avoided. And those are the ones that have an antihistaminergic property, such as the tricyclic antidepressants. These include amitriptyline, nortriptyline, doxepin, and mirtazapine. These should be absolutely avoided in restless legs. Dopamine blocking agents are often used to treat mood problems, and those are not good in restless legs. This would include uh, things like Haldol or clozapine, or some of the newer ones like olanzapine, Seroquel. Um, Certainly avoiding anything that antihistaminergic like Benadryl. Most or many of the over-the-counter sleep aids will contain Benadryl, so those should be avoided. Many people have gastroesophageal reflux disease. Those medications can worsen restless leg syndrome. And then keeping physically active to it can help with restless legs. Okay, the medicines that are used to treat restless legs, unfortunately, can also cause depression. So this gets very, very tricky. So the first line agents, the alpha 2 delta ligands, gabapentin and pregabalin, can be very, very useful in treating restless legs. Unfortunately, they can cause depression. Um, it's more likely at higher doses, so more than 1,500 milligrams of gabapentin or more than 300 milligrams of pregabalin. And I'll talk about this later on too, but it's very important as a patient that you really, whenever you're started on medications, that you kind of catalog what is happening to your restless legs, but also your mood, so that if you do develop side effects, depression, that you might be able to determine what it is that is causing that, because you might not have a provider that is going to be able to do that. And sometimes we can't, because if you can't, if the patient can't give us information, then it is very difficult for even a very astute clinician to figure that out. Opioids also, depression, very common. And in particular, I would say methadone and buprenorphine, and methadone maybe a little bit more. There can be a sense of doom, crying spells. We'll talk about this a little more in the context of treating augmentation, but any opioid can cause depression, unfortunately. And then you have the dopamine agonist withdrawal syndrome in the setting of augmentation, when you're weaned, appropriately weaned off the dopamine agonist. So dopamine is this neurotransmitter that acts in the brain and gives us a sense of reward and a positive feeling. And so if you are getting a lot of that and then take it away, you could imagine that you can have depression. So that can happen. We'll talk about that a little bit more later. All right. I did take a couple of questions that that people had submitted, and I thought they were interesting questions. So I put this one in the talk. How can I know if my depression is due to sleeplessness, RLS, or medicine? And this I alluded to already. Right. So we talked about whether the depression associated with restless legs works through sleeplessness, insomnia, or there's something about the restless leg itself. And I don't think anybody knows, but I think it's probably a combination of both. Because, like I said, with that, if even people without restless legs, if you just woke them up every night 3 to 4 times, they might become depressed. So there's something about that. But I think that there's something about restless legs itself. And in the study that I'm doing, in with the hormones that I'm measuring, one of the hormones, the alpha melanocyte stimulating hormone, is known to cause kind of uh, um, anxiety and socially isolated behavior in animals. So I think that there is something about potentially increased levels of particular hormones that might also underlie depression and restless legs. Now, this is an interesting question. This I alluded to also, or is it medicine? And so this is where it's very important for you to be very proactive in your own care, because it's so common for um, medications that are being prescribed you to treat your restless legs to cause depression. So it's important for you to note, probably in a log of some sort, the date that medications are started and even when doses are changed. And you should note if you're having side effects, including changes in your mood. Because, like I said, you may have an astute provider, but often you may not have an astute provider that's not able to kind of think about this. And so you need to be your own advocate. So you should really think about the timing of your depression onset, the timing of medications. Like I said, keep a log. But some of you may be in the position that you don't know, because you've been on some of these medications for years and you might have been depressed for years. So it's really not. So you don't know, and therefore a clinician will not know. And if you are very depressed and you think it's a possibility that it's one of the medications, then you have to find a provider that's willing to say, okay, it is possible, so I'm going to take you off of this medication. And obviously they're going to have to put you on something else. And that can be very complicated, but that's something that I do all the time. I do it a lot. So you need a provider that will work with you. Okay, so here we talked about this a little bit, but I think it's important to talk about it again, because it's something that is very, very common, is the depression and the treatment of augmentation. So like I said before, so for those of you that don't know, augmentation is a worsening of restless legs that occurs in the setting of being on a dopamine agonist, usually for years. Dopamine agonists include pramipexole or Mirapex, ropinirole or Requip, and reticodine or Nupro. And so those medications, while they're effective initially to treat restless legs in the first few months or even few years, over time, they will actually make restless legs worse. Doses need to increase, and then restless legs get better, but then it gets worse, and doses increase, and so on. And so to treat that, you have to take people off the dopamine agonist, taper it off, but they can have this dopamine agonist withdrawal syndrome that includes depression. Like I said, dopamine is the neurotransmitter that helps us feel a sense of reward and pleasure. And if you're getting a lot of that, you might have a lot of it when you're taking the dopamine agonist, but when you take it off, you could imagine that you might feel the opposite way. Unfortunately, the two uh, um, first line treatments for restless legs, gabapentin and there's a misspelling here, pregabalin, are also associated with depression, usually at higher doses, because they're kind of, you can imagine that most things that treat, many drugs that treat restless legs are kind of central nervous system depressants. And so can be associated with restless legs. And in the treatment of augmentation, I always try to get people off the dopamine agonist with either a gabapentin or a pregabalin, a non-narcotic, but I would say probably in about 2/3 of cases, we will need to use an opioid. And so the opioids, depression is very common with them. And I would say, in particular, methadone and buprenorphine, unfortunately, probably the two most effective opioids to treat restless legs are probably the two that are most commonly associated with depression, at least in the setting of using them to treat restless legs and augmentation. So it's not uncommon for me to have to go through 3 or 4 or sometimes 5 different opioids, because what will happen is that, I get someone off the dopamine agonist. I put them on gabapentin, but they still have severe restless legs. I will prescribe methadone and they will be controlled, but maybe after a month or two, they might say, I'm depressed. And I go through the whole thought process. Well, is it the dopamine agonist withdrawal syndrome? Are they on a combination of gabapentin and methadone? In which case, I might try to taper the gabapentin to off. But I found that a lot of times it does seem like it's the opioid itself that is making the patient depressed. And so by depressed, I mean that the family will often say, this is not the same person. There's a lot of crying. There's a sense of doom. It's just doom, which is a very dark feeling. And um, and it's very pervasive. And so I will then switch. So if they're on methadone, I may go to buprenorphine, but I tell them that unfortunately, it's possible that you're going to have depression with buprenorphine as well, but you have to try different things. And then if that doesn't work, I will go to morphine, MS Contin. I may try oxycodone, and sometimes OxyContin is better than oxycodone. It's just harder to get insurance to pay for it. And then may even try tramadol. So it's important that the provider you're with, the problem is that there are not that many providers that would be willing to, or it is difficult because to have providers switching from opioid to opioid, many will not feel comfortable. But yeah, but certainly living with severe depression is not something that anyone should have to deal with. Okay, so we did talk about this a little bit, but I think this is an interesting thing to talk about this morning time. Reminds me of a study that I read in the journal Sleep, in that in the morning, it's normal for everyone to have a low mood because you just woken up, you're kind of sleepy, you're just not in a good mood. It's not that common for people to be very happy first thing in the morning. It happens, but those people usually are the people that you're very annoyed with. So everyone is kind of at a low mood in the morning. Luckily, the mood increases as the day progresses, and under normal circumstances, a person can engage in socialization or work to raise their mood. But if there hasn't been much sleep, your reserve and your kind of desire to engage in socialization and work are going to be decreased, and therefore it's going to be harder for you to kind of get out of that feeling. So just kind of just having a, like I said, everybody starts at a low point, and most people are able to increase, but if you haven't had much sleep, you're less able to increase. Okay, so what can you do to limit your sleeplessness? And some of this may seem kind of obvious, but I see tons of patients with restless legs that still are not doing this. So I imagine that many of you could be helped by this slide. So a moderate amount of exercise. Exercise helps sleep. It's just important not to do it at night. You could do it anytime in the day or even in the early evening is fine. Limit alcohol. Alcohol itself may help sleep onset, but is going to prevent continuous sleep. And in the case of restless legs, it's going to make restless legs worse. You should limit caffeine. If you're having problems with falling asleep or staying asleep, you really shouldn't have much more than one caffeinated beverage. If you snore, um, you should get a sleep study, particularly if you wake up with a dry mouth or you urinate frequently. Testing for sleep apnea is really important because if you have sleep apnea and restless legs, if your sleep apnea is not treated, your restless legs is going to be difficult to control. Avoid blue light at night. Do not watch TV in bed. And then, of course, if you haven't, you should seek help from a sleep specialist. Okay, so we talked a little bit about this, but I think it's such an important point that we should reiterate it. So it's unfortunate that many antidepressants, almost all antidepressants, unfortunately, will make restless legs worse. The only one that won't is Wellbutrin, bupropion. Bupropion is a good medication. I prescribe it to patients that have restless legs and depression, but it's said to be activating. So if you have a large anxiety component, it might not be the best. Therefore, it's important for you or for people that have restless legs and have depression. Sometimes you have to use an antidepressant, but you should just know the ones that you can take and know the ones that you should not take. So, like I said, the antidepressants that have antihistaminergic properties should be avoided. So mirtazapine should never be used in someone with restless legs. Tricyclic antidepressants like doxepin, amitriptyline, nortriptyline, or imipramine should not be used for restless legs. I would say in rare circumstances, if you truly have somebody that has tried 15 or 20 different antidepressants and the only one they respond to is one of these, then possibly, but that's probably extremely rare. SSRIs are probably less exacerbating for restless legs than SNRIs, but I do have some patients that are on venlafaxine, and I don't suggest to discontinue it because they're using it for depression. But if I were to start a patient on an antidepressant with restless legs, which I do, I will use an SSRI, and I will use probably either sertraline or citalopram or escitalopram. These just seem to me to be the most benign in terms of restless legs. That being said, they certainly can and probably will cause a little bit of a restless legs worsening. But when you are depressed, treatment of depression is really important. Okay, so again, we talked about some of this, but I think we could reiterate what can you do to help your depression: moderate exercise, limit alcohol, seek medical help to treat your restless leg, seek psychiatric help to treat your depression. If you do so, have your restless legs doctor communicate with your psychiatrist, but don't rely on this. You should know what antidepressant medications to avoid. Get a psychotherapist, which could be a social worker, can be a trusted friend. People are using more um, um, online resources, which has helped. Online resources are more widely available, hopefully keep the costs low. But talking to somebody about your thoughts and sadness is important part to treating depression. Okay. Treatment of depression: limit exacerbating factors, decreasing alcohol and recreational drugs, avoid unhealthy eating, don't be sedentary, exercise, clean up the sleep hygiene, limiting caffeine, limiting blue light at night. Talked about this before. Antidepressants may be necessary, may want to start with bupropion, but this may not be the best if there's a large anxiety component. SSRIs like sertraline, citalopram, escitalopram. Psychotherapy, talking is critical. Okay, we talked about this, but not all of it. Behavioral, we talked about. Important that your iron and ferritin are optimized. So your ferritin should be above 100. You should get your iron and ferritin tested when you have fasted and you haven't eaten anything with iron in the previous two, or nothing rich in iron, nothing like red meat or hamburger in the previous 2 days. If you're taking iron supplements, you should discontinue the supplement for at least 5 days and then get it measured. Sleep apnea, really important to treat sleep apnea, and therefore if you haven't been tested for it and you snore and or have a dry mouth, you should be tested for it. Avoid dopamine agonists, using gabapentin or pregabalin, using opioids, but knowing that these medications, even though they can treat restless legs, might potentially cause depression. Okay, so let's see. So we have a little bit of time. I'm going to go very quickly through this. So we did a study where we studied suicidal behavior through this questionnaire. Have you ever thought about or attempted to kill yourself? How often have you thought about killing yourself in the past year? How often have you ever told someone that you were going to commit suicide? How likely is it that you will attempt suicide one day? And high risk of suicidal behavior was if there was a score of greater than or equal to 7. And unfortunately, we found that the prevalence of a lifetime suicide plan or attempt was a lot higher in patients with restless legs, about 26% compared to about 7% in controls. And then similarly, the high suicide risk with a score of greater than or equal to 7 was 30% versus about 9%. This is the National Suicide Prevention Lifeline. Could take a screenshot or a picture of this. You like 1-800-273-8255. So, in conclusion, RLS is associated with depression for multiple reasons: insomnia, sleep apnea, medication side effects. It's important to know how to help yourself: sleep hygiene, exercise, limit alcohol, know what medicines should be avoided. When you have restless legs, catalog potential side effects and medication start and dose changes. Suicide is the most severe consequence of depression, both RLS and depression. However, the good news is that both restless legs and depression are very treatable. So there's no need for any person to be suffering chronically from either of these because they're treatable. And if you are someone that does suffer every night from these, then contact the RLS Foundation for the restless legs piece. For depression, start with your primary care doctor, and hopefully they can connect you to the help you need. Okay, with that, I will stop.
All right. Thank you, Dr. Koo, for your presentation. This is a topic that is extremely relevant and very important to the RLS community, and very timely given that October is Mental Health Awareness Month. As Dr. Koo mentioned, we do have RLS Foundation resources. We have a wonderful network of volunteers who host support groups weekly. We have virtual weekly groups. We have local support group leaders who host, more uh, intimate meetings that really serve their cities. We have a discussion board. And so if you're seeking additional support, please reach out to us and we can try to connect you with somebody who can understand your experience. We are going to jump into, for the last 10 minutes, just a couple of questions that were submitted by the audience during your registration. Now you did review this, but I just kind of want to, give you the opportunity to summarize it very quickly. So the first question that we have is, how can I tell if my bad mood is depression or just a bad mood?
Right, yeah. It's a good question. We did touch on it a little bit, but it's normal to be in a bad mood. Like I said, people's moods are at the lowest in the morning, and we're able to increase our mood through a combination of waking up, moving around, socializing, and doing work. But kind of if you're not able to kind of snap out of it, and if the feeling of low mood is pervasive, lasting more than at least 2 weeks, and if it's affecting your ability to function either at work or at home or at school, then probably it's more than bad mood. It's probably going into the realm of depression. So I would say the two key things are going to be duration. So a bad mood, bad mood should only last for a few hours, I imagine. But depression can last for weeks, months, years. So time, and then how it affects your ability to do things. So a bad mood, certainly a bad mood could affect your performance, um, but if it's affecting your performance to a greater degree, but for consecutive days or weeks, then you're probably not just dealing with a bad mood.
All right. So the next question is, why do I get a sense of doom and gloom when I'm woken up for a second time during the night with RLS?
Okay. Yeah, so it's probably going to be a little bit difficult to answer specifically, but I could give some possibilities. So, like I said, nighttime is lonely. And so in general, nighttime is thought to be a time, well, most people are asleep. So there's a general sense of isolation when one is woken up. Unfortunately, I'm not sure about most, but suicides are disproportionately represented at nighttime. Okay. So it could be because of that, the the doom of waking up could be because if you have to work the next day, you feel that, oh gosh, I've woken up and I'm going to feel horrible. And you might have a sense of doom because of that. Is there something specific to restless legs itself? Like I said, maybe, the hormone measure, the hormones we're looking at in restless legs are associated with depression um, themselves. So is it possible? I guess it is possible. Is it a medication that you're on? That's another thing that is possible because a sense of doom shouldn't really be happening. But if you truly are getting a sense of doom, this is something that does occur with methadone and or buprenorphine. So if you're on either of those, you probably should talk to your provider.
So kind of on that same topic there, maybe of looking at like, medications that can potentially impact your mood, are mood swings usual for some of the medications that are commonly used for RLS? Is that a typical side effect?
Again, this is a little bit difficult to answer because of mood swings, that's kind of a colloquial term, so I don't exactly know what is meant by mood swings. So yes, like we talked about, depression is certainly caused by some of the medications. And so I would say probably, because if you're depressed and if you're kind of on the precipice of depression and not depression, I guess that could be a mood swing, because sometimes you're happy and sometimes you're depressed and you're inconsistent, and that could be construed as a swing. So I would say yes. So just about any restless legs medication can be associated with that. So gabapentin, pregabalin causing depression, the opioids causing depression, the dopamine agonists cause compulsive behavior. And so I think those could be, and some people feel enraged on them, so those can cause mood swings. So I would say, yeah, any of the restless legs medications can cause that.
Similarly, we had a question that asked, does the use of buprenorphine cause sleeplessness? And we can probably expand that
Sleeplessness.
question to, yeah, do any of the, opioids or potentially other RLS medications cause sleeplessness?
Yeah, any medication at all can cause sleeplessness. However, the opioids are probably more likely to cause sleeplessness than many other medications. So gabapentin and pregabalin are thought to mostly help sleep, but I have had patients say that they took them and they couldn't sleep. So it's possible. That's not uncommon with opioids. And buprenorphine, maybe even in particular. I've had several patients on buprenorphine, and it's not uncommon that you treat someone for augmentation, get them off the dopamine agonist, put them on an opioid, and the restless legs is gone, but they cannot sleep. That is very common. So if that is the situation, you may want to be trialed in a different opioid. I It's not uncommon for me to add a hypnotic like Zolpidem. But certainly if you're drinking caffeine or you snore, you should have a sleep test and reduce the alcohol, or I say caffeine. Yeah, reduce the caffeine, because those obviously can be associated with sleeplessness.
That's interesting. Um, the next question is, how can I stay in a good mood while being sleep deprived because of my RLS? Do you have any tips for that?
That's a hard one because,
Yeah.
like I said, your mood, everyone's mood is the lowest in the morning. And if you don't sleep, you don't have a lot of reserve and you don't really want to do those other things. All I could say is, I guess sometimes you may need to kind of force yourself to get up and maybe exercise. Um, Maybe force yourself um, to go out and socialize, perhaps. Um, it is difficult. What I would suggest is that if you are not sleeping a lot, that means that your restless legs and or insomnia are not being optimally treated, and working with your provider to try to improve the situation.
I think we have time for one more question. So this last one is, some days I get 8 hours of sleep, some days only 3 or 4. How does inconsistent sleep time affect someone's mood?
Well, it's certainly going to have a negative impact on mood. Um, Let me see how I can answer that in another way that's not so obvious. Um, well, I mean, maybe in this way of, when you have more sleep, you have more reserve to do things to increase your mood, like socialize and do some work. And um, let me see. And I think it's going to be a similar answer to the last question, is that, there seems, if you are having inconsistent sleep, I know it's somewhat easier said than done, But to look at all of those things, the caffeine, the alcohol, do you have sleep apnea, exercise, medications, diet, and then if those are all optimized iron levels, then talking to your provider about either adjusting a restless legs medication or adding a hypnotic medication.
Awesome. Well, thank you so much again, Dr. Koo, for joining us today. And I want to thank everybody who joined us as well. We hope to see you at our next virtual event, which is our November webinar with Dr. Mauro Manconi, who's the director of the Sleep Center Neuro Center of Southern Switzerland. And that will be taking place on Thursday, November 20th. Where he will discuss common occurrences of restless leg syndrome during pregnancy. So to register and find out more information, please visit www.rls.org/attend events. All right, thank you so much, everyone, for joining, and thank you, Dr. Koo. Enjoy your evening.
Thank you. All right, bye-bye.